Okay, next up we have, so I'm just looking at my list, another international colleague of ours, Dr. David Kuter, all the way from Harvard in the USA. And David will be talking about what is new in ITP. Professor Kuter.
Thank you, Mervyn, and thank you, Adrian, for asking me to come talk to you. It's been a couple of years since I was here in person, but I think I talked last year by virtual. I'm going to pretend you're all in a telemedicine monitor here. But let me start by saying that my mother was a school teacher. And when she was 100 years old, she said, "What do you do, actually?" And she said, "I know you do some scientific stuff. Could you explain it to me? And don't dumb it down, because I'm not stupid." So I'm not going to dumb down much what I'm going to tell you about in terms of new therapies, but I'll talk to you about some new therapies and hopefully make it comprehensible. These are my disclosures. I work with many companies that develop therapies for ITP. And this is a nice old picture from 1910. This is a blood cell, a bone marrow cell called the megakaryocyte, and it's making, this is the bloodstream here, it's making platelets as it sheds into the circulation here. And this is an old picture of how you all make platelets in your circulation. If you go to more modern pictures, this is a picture of a mouse who's, you're looking at a megakaryocyte here, putting a bit of its cytoplasm into the circulation. You see platelets budding off here. You'll see another megakaryocyte down here. It's pushing it out here. And this is how you make platelets in your circulation. You guys are doing this every minute of the day, and if you have ITP, and maybe doing this at a very fast or very slow rate, but this is how you make platelets. And when you have this problem, there are two issues. One is you may end up destroying these platelets, or you may end up destroying the source of the platelets called the megakaryocyte. So this is what's going on in you. And to make an even longer story short, this is Dr. Provan. He's had an exercise program recently. He's got big muscles. He makes platelets in his bone marrow. They enter his circulation, and after about 7 to 10 days, they get destroyed by a normal process. If Drew gets ITP, his rate of platelet destruction, primarily in his spleen, increases. His platelet count drops. And so this is the genesis of part of the ITP picture that Dr. Semple related to. It was thought for many years that your bodies were good and compensated for this, but that's not true. What happens in ITP is this: you destroy platelets at a rapid rate and you don't make them fast enough. So there are two components to ITP: increased destruction of platelets and inappropriately low platelet production. This leads to how we treat ITP, both on a current scheme and also on a future scheme. And I'll talk to you about the future things in a second. But in terms of ITP therapies here, in the white are things that will decrease platelet destruction, such as your favorite drug, corticosteroids, or rituximab, or have your spleen taken out, which is a main site where platelet destruction occurs, or you can give people IVIG or fostamatinib, which blocks the other cells called macrophages that chew up these platelets. And finally, on the other side of the fence, you can increase platelet production by these things called thrombopoietic agents, and also corticosteroids do this. So these are the two levers we have to play with in terms of current therapies. As we go forward in the future, these two arms of ITP, production and destruction, are the targets that we focus on developing new drugs. So let's talk about the first part of ITP, which is that you all with ITP are not making platelets adequately. Your bone marrow is being suppressed by antibodies, and this is a cartoon like Dr. Semple here. We've got antibodies, lymphocytes, and this makes the megakaryocyte, which is the cell that makes platelets, die off. And all the cells that are trying to make platelets in you don't make platelets very effectively. And this gives you the thrombocytopenia. So the question is, could we fix ITP by reversing this process? Could we have you make more platelets in your circulation? And the answer is yes. And this is a list in red of things that are available: corticosteroids, the TPO receptor agonists, such as rimiplostim, L-trombopeg, avatrombopeg, and heterotrombopeg, are all TPO receptor agonists that can make you make more platelets. And I'll describe how that happens in a moment. But there's a new thing that we're developing right now, which is very nascent, and I'll give you more data in a year or two, and that's using a low-level laser light like a tanning booth that might make your megakaryocytes make more platelets. So let's look at the thrombopoietin receptor agonists. And how many of you have been on an L-trombopeg or rimiplostim or avatrombopeg? Oh, okay. I'm speaking to the choir now. So the question is, do you guys know how this stuff works? I mean, we invented these drugs 10 or 15 years ago. And what's happening here is you got this megakaryocyte in your bone marrow being attacked night and day by antibodies and lymphocytes, and it's trying to die. And then you take your L-trombopeg or rimiplostim, it binds to what's called a receptor on this megakaryocyte. And instead of dying, the thrombopoietin comes to the rescue, and this megakaryocyte now lives and allows you to make more platelets. And for those of you that participated in clinical trials, this is a clinical trial of a new drug called avatrombopag. These are the patients who got the sugar water pill, and these are the patients who got the active drug. And you see the platelet count rose rather rapidly and then sank down. Some of you might have had this experience yourself. You get a rapid rise in the first couple of weeks, and then you sort of crash. Well, you rose because all those dying cells called megakaryocytes are now living and making platelets. So that's why you have this huge surge. So if any of you have had the experience, you just wait a little longer, it dampens down, and you don't need to change the dose too much. But this is how the thrombopoietic agents tend to work in ITP patients. Let me flip gears and say that the other thing I'll describe to you is the fact that these cells called megakaryocytes require a lot of batteries. This is a lithium-ion battery in a car, or in this case in your megakaryocyte. This is fully charged, and you need plenty of energy to make platelets from these blood cells in your bone marrow. And what we've shown recently, and we'll elaborate on this more in the coming months, is you can take in a tissue culture cell, this is outside your body, you can isolate what are called stem cells, put them into an in vitro culture, and you can grow megakaryocytes in this device. If you irradiate this culture plate, like give it a tanning booth dose of low-level laser light, this is a laser 810 nanometers, you can increase the number of megakaryocytes fourfold, you can increase the number of platelets tenfold in this test tube. And so the question is, could you do this in a whole human being or a mouse? Well, we're not quite to the human stage yet, but we've done this in mice. And if you make a mouse have a low platelet count like this, it then recovers. But if you give a mouse this low-level laser light on these days, the platelet count rises rather fast, and this is because the low-level laser light goes straight through a mouse. It goes 8 centimeters into a human or straight through a mouse, and this lets us do the following, and this is my interpretation of what's going on here. And this is the last time I'll show you this slide, I promise, okay? So this is the attack. This is your bone marrow megakaryocytes fully charged. You then attack them with antibodies and lymphocytes. You got the drill right now. And then the battery gets discharged, and this causes the megakaryocyte to start to die, and it tries to die in us. And if you put it in a tanning booth and give it low-level laser light, you recharge the batteries. The megakaryocyte lives, and it makes platelets. And so we have a larger monkey model of this right now. We've done the same thing in monkeys, and hopefully in a couple of years we'll have a tanning booth for ITP patients that might give you, it doesn't tan your skin, but it might make your megakaryocytes up. But these are the things that we're looking at right now to look at production, to boost your production rate. Let's flip the gears. The classic story of ITP is you destroy platelets. And this is a lovely picture of my second favorite cell. This is the macrophage. John talked about this. This is a macrophage chewing a platelet that's coated with antibodies here. And here's a platelet which has already been eaten by the macrophage. And this is a model that we are using and many companies are using to design new therapies for ITP. It also explains many older therapies. And so let me show you, this is what's called the surface membrane, the surface of the macrophage. So macrophage, megakaryocytes, can we say this together? Macrophages destroy cells. Megakaryocytes make platelets, so those are the two M cells. So this is a macrophage. This is a thing called a receptor on it, and here are your platelets. And if you develop ITP, guess what? Antibodies come along and try to kill your platelets. So the first thing you might think about doing is what? Can we make the antibody disappear? And the answer is we do that in part with taking your spleen out or giving corticosteroids. The drug rituximab has some activity here, and IVIG also can do this in several ways. But what's happening right now in clinical studies is we're using various drugs which have these crazy names, anti-CD, like daratumumab and letolizumab and bortezomib. These are great tongue twister names. They're also great for playing board games. But anyhow, these are things that decrease your ability to make antibodies of all types, both against platelets and also against other things. And there's another series of molecules called anti-BAFF cells. These are things that turn off your lymphocytes that John just showed you that are making platelets. And then finally, the newer one is things that actually physically make the antibody disappear. When Dr. Newland was a boy, this is a couple years ago, he actually showed that if you took people and put them on a machine that took the plasma away, you could make the antibodies disappear and treat ITP. It did work very well, did it, Adrian? But it did have some response. But basically, I'll show you a way that there's a now molecule that might make the antibody that's causing your ITP disappear. And this is a Drew Provan cartoon. Thank you, Drew. This shows a cell that's in your body. It lines all your blood vessels. And every day, this lining cell of your blood vessels chews up about a third of your plasma volume, the liquid part of your blood. And what happens is it ingests antibodies, and they're protected from death by binding to a thing called a receptor whose name is FcRn. And then it goes down here, and other proteins are destroyed, but the antibody gets recycled to the surface. And that's why antibodies against ITP live for about 21 days in your circulation. So the question is, can we poison this processing plant down here? And you can do that with some molecules that inhibit this thing called a receptor. And then all antibodies, the bad ones and the good ones, get chewed up, and you become lower in terms of your antibody level. And this has been studied recently a fair amount. And this is a molecule that you might have heard about called efgartigimod. Did anyone participate in the study? Maybe no. This is a molecule that binds to this thing called a receptor and blocks it from binding good antibodies or bad antibodies. And so what happens here is if you give patients this drug called efgartigimod, which sounds like a Lord of the Rings name, you basically can drop your antibody titer down a fair amount. I think I've lost the laser pointer here, but anyhow, you can see the lower line drops down a fair amount. And what happens is if you have ITP, your platelet count in the upper line tends to rise. And this is a new therapy for ITP, which is being studied, and there'll be more studies going forward in the future. So that's one approach. Going back to our system, we've got our antibody up here. The next thing is what else happens? If we can't make the antibody disappear, what happens next? Well, the antibody binds to your platelets and causes a complex to form. And then here's where something interesting happens. And John mentioned it in a very minor way. We have a thing to accelerate this process called complement. And that's not a pleasant thing, but the complement is a thing that's in your circulation that then binds the antibody and makes it a super antibody. It sort of makes it disappear faster, and it goes to your liver and is removed primarily by the liver. And this is a system that amplifies the immune response and may make your ITP worse. And so the question is, can we inhibit this stuff called complement? And I apologize for this. I'll pretend you're my mother and say, Mom, I apologize for the slide intensely. But basically, complement is this stuff right here that when an antibody binds to your platelet, this thing called complement attaches to it, adds some more crazy complement stuff here. This leads to the liver and spleen chewing up the platelets even faster, or some of them just go pop in your circulation. So complement is an acceleratory mechanism in the immune system, and by inhibiting this thing by a drug called sutimlimab, which we've recently developed for a different disease, you might be able to turn off complement. And if you do that, this is a study that I'll take you through briefly. It was published about 2 weeks ago. In the blue here is your normal complement level. We make it disappear with this antibody. It becomes low. And in ITP patients in the green, the platelet count rises within a couple hours to almost normal levels and remains elevated until the drug stops. So this is called complement inhibition, and there are some intravenous and oral agents being developed right now in ITP to make this process get turned off. Well, going back to our story here, we've got our antibody, which we couldn't make disappear. We couldn't block the complement. So what happens next? What happens next is this thing binds to this receptor on the macrophage right here, and it activates a whole bunch of other things. This is like pushing down the gas pedal here. And what happens is a whole bunch of other things down here result in the platelet being chewed up like that picture I showed you and making your platelet count become less. So the question is, can we go back to this cartoon and either prevent binding up here or prevent the internalization shown here? And let me just show you that there are things we are developing right now that will prevent binding here, and there are other things that inhibit this step here and this step here that might be used to turn off the chewing function of the macrophage. Macrophage, megakaryocyte, got the distinction here? Okay, so let's go back to what's available. Things that affect the macrophage are a list here: corticosteroids, vincristine, vinblasting, having your spleen taken out, or IVIG, or the new drug fostamatinib, which I think some of you take. And I'm going to focus on IVIG, which is an old and friendly drug whose mechanism of action is still not fully worked out. And I will simply say one thing. IVIG is a pretty neat drug. It has got a variety of actions, and I will show you this cartoon one last time. This is the platelets up here being stuck to a thing called a receptor. And when it hits this receptor, a whole bunch of things get activated and you chew up your platelets. But what happens in IVIG is only a small part of IVIG works, and it inhibits this process by making this red thing up here as a stoplight prevent internalization of the platelets. So how does IVIG do this? And here's the interesting part. If you look at that liter of IVIG that someone infuses into you at great cost, only about 1% is biologically active, and that's because it's got some sugar residues, which is the purple marks here. And this is a unique, on the right-hand side is a unique type of IVIG called sialylated IVIG, and this is the active component for ITP in this situation. And what you can do is you can chemically buy large amounts of IVIG, most of which doesn't have these sugar residues on it, add some sugar residues, and it becomes a super IVIG. It's 10 or 20 times more potent than regular IVIG. The other thing you can do, and I will take you this, the antibody molecules, IVIG has got a portion out here and a thing down here, which is called the FC portion. All you need for effectiveness in ITP is this part down here. And what you can do, and this is the second IVIG story, is you can create these things called FC molecules in a test tube. So this is all in a test tube. You can make a single component or a dimer or a trimer, and this molecule he'll call, which is called trimeric FC, basically turns off your macrophages from working, and it sort of makes them all passive and turns off your consumption. And this is another new molecule that's being developed. Finally, in terms of new structures, I mentioned before that you turn on, when you have this receptor binding up here, and again, I'm losing my light, this thing called BTK, which has got a thing called rilzabrutinib attached to it, and SIC, it's got a thing called fostimid. These are molecules that will inhibit the internalization process of this macrophage cell. And the one I'll talk to you about briefly is the one that we're developing right now, and I think Dr. Cooper and others, yes, I think our whole team here is here right now. I have published a paper recently looking at this drug called rilzabrutinib, which inhibits one of these processes. And of the 40 patients, of the 45 patients who were treated, 18 patients had their platelet count rapidly rise to normal or above 50,000 and remain there for up to 4 years. The other patients didn't have a response. And what's neat about this drug is it worked real fast within sometimes 4 to 5 days. Number two, it had almost no toxicity, which was really cool compared to the other things we tend to use. And lastly, 95% of the weeks was the platelet count over 30,000, so it maintained a good platelet count. And you'll hear more about this drug as it's being made. So to summarize, and I think I'm almost on time here, Mervyn, for a change, the current medical therapies for ITP are effective in most ITP patients. Corticosteroids, as you heard, is a brief or even briefer exposure. The TPRAs, as you heard about, have a very high response rate of 85 to 90% in clinical trials. Rituximab, I think, is effective and probably should be reconsidered in the post-COVID era for patients if you restrict it or have patient preference here. And fostimid may be an effective alternative. I think the other thing that we've learned in the last couple of years is the early use of non-steroid therapy, which is primarily things like TPO-RAs and rituximab are probably important in this. And their upfront use at the initial diagnosis should be thought about or be considered or certainly be studied in patients like this. Many of our patients will be treated right now in Boston with a brief course of corticosteroids and started on a TPRA on the second day of their hospitalization. Finally, our goal is to avoid splenectomy, at least for the first year, and probably for all of our patients forever if we can. And finally, as I said, there are a lot of novel agents coming along. There are inhibitors of these molecules called SIC and BTK, others who've got longer names. We can inhibit complement. We can inhibit the neonatal FC receptor. I didn't talk to you about a drug called neuraminidase inhibitors, and there are modified forms of IVIG which may be available that may give us a very rapid onset and turn off the whole process. But there's a lot of activity in ITP right now. I think we're all very optimistic, and I can speak for my colleagues here that these new drugs will find a home someplace in ITP. But the good news right now is our current armamentarium is actually pretty good for most things. And I'll stop and say there's not a cure yet, but this is a blood purifier available in Canada, in Halifax, Nova Scotia, back in 1890, which I have a bottle of at home. All right, thank you.